Should we start? Good afternoon. So, topic for today is hearing loss. You must all be very aware of the fact that you are the first batch of NMC's lab जिसमें आपको competency based curriculum follow करना है 19 ना अच्छा 20 चलिए in any case we have to read this topic, so we're going to read hearing loss today. So we'll be discussing the overview document, the hearing loss, the history part, the clinical features, investigations and management. So what is hearing loss? A partial or total inability to hear. So how does WHO defines it? A person is said to have hearing loss if they are not able to hear as well as someone with normal hearing. It means that examiner should have normal hearing, meaning hearing threshold of 20 decibel or better in both ears. If in a given ear the hearing is normal, say within the range of 20 decibel, it is considered the normal hearing ear. In opposite ear, it can be more than that. Fine. It can result from problems within the ear, like outer, middle and inner ear, the vestibulocochlear nerve as in case of say cranial nerve number 8, or the auditory system, anywhere the problem in this system. Or in the context of this chapter, the hearing loss refers to an audiologic diagnosis of the hearing threshold outside the range of typical hearing. So we'll be focusing on the audiological diagnosis. So we being clinicians, बाद में देख लेना, इन्हीं को ही देखते हो पूरे दिन भर. क्या मतलब तुम्हारी क्लासमेट ही है भाई. ये प्लीज डोंट डिस्कस एनीथिंग हियर. बेटा एक गेट लगा देना, इसको बंद कर दीजिए आप. So we will consider hearing loss whenever we find a audiological diagnosis for it. We'll get a diagnosis for it audiologically, then it would be considered as hearing loss. So it can be bilateral, unilateral, symmetrical, asymmetrical, progressive, sudden, fluctuating, stable, can be present at birth or acquired. So if we classify the hearing loss, there are basically two types. One is organic and other is non-organic hearing loss. We divide organic into three types: conductive, sensory neural and mixed. Further dividing sensory neural into peripheral and central. Peripheral being sensory and neural. Sensory means cochlear nerve, neural means 8th vestibular nerve. Central organic hearing loss due to brainstem lesions, thalamus or temporal lobe lesions. Mixed hearing loss means conductive as well as sensory neural component, if a hearing loss has both. In non-organic, we have mostly, there are multiple subtypes, but we are more concerned with malingering and psychogenic hearing loss. So, hearing loss can be described by the variation in type, degree and configuration. Three basic types are, अभी हमने पढ़ा था, SN loss, conductive and mixed. So, SN loss is due to cochlear and neural component, that is cranial nerve number 8. Conductive, whenever there is problem in conduction of sound waves through the outer ear canal, tympanic membrane or the middle ear. Whatever pathology is there, it can cause the conductive hearing loss. Third is mixed. It is the result of damage to conductive pathway and to the nerves or the hair cells of the inner ear. So the degree of hearing loss refers to the level of severity of hearing loss. Whenever we talk about or we say that this degree of hearing loss is there, we mean by this the normal, minimal, mild, moderate, and If we see the table, the degree of hearing loss, if we say that it is wow. So if a person is supposed to have a normal hearing, the loss is in the range of -10 to 15 decibel. So till 15 decibel loss, we'll say that person has normal hearing. It is considered to be absolutely normal. So as we go down, minimal is 16 to 25, mild is 26 to 40, moderate is 41 to 55, moderately severe is 56 to 70, severe is 71 to 90, profound is more than 90. Decibel hearing loss is decibel in hearing level. The degree of hearing loss can have significant implications for an individual, like limiting the ability to understand the speech and background noise, decreasing the enjoyment of music, impacting overall quality of life. So what are the causes? If we see for conductive hearing loss, the absence of malformation of the outer ear, the canal, the middle ear, benign tumors anywhere in the system, fluid in the middle ear space from upper respiratory tract infection or middle ear infection, head trauma like skull fracture, damage to tympanic membrane or middle ear structures, impacted wax, infection of the ear canal, swimmer's ear, otitis media, otosclerosis, perforated tympanic membrane, poor eustachian tube function and presence of foreign body. These all are separate chapters. These all are separate chapters. You're going to study further. Otitis media, otosclerosis, ये सब आगे आपको पढ़ाए जाएंगे अलग से. Eustachian tube, C1. Causes of SNHL: autoimmune ear diseases, benign tumors, enlarged vestibular aqueduct, genetic causes like Char syndrome, Pendred, Waardenburg, and non-syndromic genetic mutations, head trauma, infections, CMV, herpes, measles, mumps, syphilis, toxoplasma, Meniere's disease, noise exposure, ototoxic medications, presbyacusis, and vascular deficits. Third is mixed hearing loss. It occurs when there is a combination of one or more causes of CHL and one or more causes of SNHL. The other one is cochlear synaptopathy, that is known as hidden hearing loss. These all questions are favorite questions of examiner, especially external, because ENT is 50% ear. If you have to pass ENT, तो ear अच्छे से पढ़ लीजिएगा, आप हो जाएंगे पास. So talking about hidden hearing loss, a loss or damage to the nerve connection between cochlea and the eighth nerve. You all must have studied कॉकलिया से क्या चलता है, आगे कहाँ जाता है, क्या सिस्टम होता है, कैसे सुनाई देता है. अगर फिजियोलॉजी एनाटमी पढ़ी हो तो याद हो तो, नहीं भूल गए, चलो फिर भी रिवाइज कर लेना. So this type is referred as hidden because it is not identified using a standard pure tone audiometric examination. It results in individual having trouble understanding the speech in noisy environment. Hidden hearing loss may be caused or exacerbated by aging, drugs, and noise exposure. So what are the clinical features? So signs and symptoms which are associated with hearing loss will vary, and they may include avoidance of social settings or reduced participation in activities, consistent request for repetition, difficulty in understanding speech, in noise, in high-pitched speakers or on the telephone, hearing other speech as mumbled, increasing the volume on the TV and other devices, listening fatigue, perception of muffled hearing. No. So what are the common risk factors for hearing loss? Number one is aging, loud noises, short-term or long-term exposure. ये सब आपको आगे पढ़ने को मिलेगा. how short-term loud noise affects your hearing, at what level, what are the consequences, and how long-term noise affects. Heredity, occupational noises, recreational noises, ototoxic drugs, multiple diseases and their treatments like cancer chemotherapy and radiotherapy, they do affect. So the most important part, being a clinical subject, आपको आगे ये पता चलेगा कि आप जब भी किसी क्लिनिकल सब्जेक्ट को पढ़ते हैं, कोई पेशेंट आपके पास आता है, द मोस्ट इम्पॉर्टेंट पार्ट इफ़ यू वांट टू treat a patient is history taking. It is the core of making diagnosis, and your diagnosis ultimately leads you to the correct treatment. If you are not diagnosing the patient properly, you won't be able to treat him or her. So what is included in history? Following are the must include components. Which side of ear? ENT is right or left? If you are saying that there is here, no, thank you, thanks for coming, please leave. Side of the ear, right or left? The duration, since when? The mode of onset, whether it is sudden or gradual. Any preceding event like trauma, cough, cold, loud noise, drugs. The progression. Fluctuating hearing loss, the causes are otitis media with effusion, parallel fistula, Meniere's disease, earwax. Degree of hearing loss, we will see in investigation part. Hearing in noisy background, that is known as paracusis willis, diagnostic of otosclerosis. Diplecusis. Diplecusis is di. What do you mean? What do you understand by di? Dipla accusis. बोलो बोलो, गलत ही तो होगा. दो क्या, कुछ दो है, चलिए ठीक है, चलो दो तक तो पहुंचे, ये भी अच्छा है. Discrimination, recruitment, these all are phenomena. They all are short questions also. You're gonna read them multiple times. ये आप इसका स्नैप ले लें, कोई इशू नहीं है ना. आराम से घर बैठ के पढ़ो और पढ़ लेना, ठीक है. Associated ear symptoms like discharge, tinnitus, vertigo, oral fullness, headache, visual disturbances, etc. The other important part is past history. Any history of trauma, surgery, drugs, fever, and family history, because hearing loss runs in families. Otosclerosis, Waardenburg, sacculocochlear anomaly. So this table is very important for you guys. Please remember this. If we have to differentiate between conductive and sensory neural hearing loss, there are certain features or criteria by which we can differentiate. Please read this. The understanding of speech in conductive hearing loss is good, but in SN loss it is poor. Understanding of speech. When someone says that I know that you are talking but I cannot understand what you are talking. Okay. Intolerance to loud sound. It is absent in conductive loss. It is present in SN loss. Speech of the patient is low in conductive and is loud in SNHL. Paracusis willis. Patient hears better in noisy surroundings because आप अपनी वॉइस का पिच ऑटोमेटिकली रेज कर देते हैं ना. आप तेज बोलने लग जाते हैं जब बैकग्राउंड नॉइज आती है, तो उसको सुनना इजी हो जाता है. सो इट इज कॉमन इन कंडक्टिव and absent in SN loss. Associated symptoms like otorrhea yani ear discharge, earache, it is common in conductive, and tinnitus is more common in SN loss. Profound hearing loss never occurs in conductive hearing loss. The maximum conductive hearing loss we can get is 60 decibels, not more than that. SN loss can be performed. Rene's test, you must be aware of these things, Rene, Weber and all, tuning fork test. प्रैक्टिकल क्लासेस अभी आपकी मई से शुरू होंगी ना, मई से ना, हाँ, तो यू विल बी well taught, don't worry. Rene test is always negative in conductive hearing loss, but in case of normal hearing or sensory neural hearing loss, it is positive. By positive Rene test, we mean ear conduction is better than bone conduction. Weber's test is lateralized to worse ear in conductive hearing loss, and other is true for SN loss. These two dictums will help you in your viva also. Whenever examiner asks what is your inference, how do you test, through, you will always say that we will check it through tuning fork test. So what are the results of tuning fork test? You have to say 3 tests basically we do to check what type and what degree of hearing loss is there. Rene test, Weber and absolute bone conduction. We'll see that in practicals. Absolute bone conduction is normal in conductive and reduced in SN loss. Pure tone audiometry में ear bone gap is present in conductive and it is absent in SN loss because there is no deficit in the conduction of sound wave to the oval window. Recruitment phenomena, tone decay, frequency threshold, they actually need a separate class altogether of at least 1 to 2 hours to understand these things. Okay? So it's my request to you, please go through all the features at least when you want to go further ahead in the readings, to know the basics कि भाई ये रिक्रूटमेंट क्या होता है, क्यों होता है, इज अ सेपरेट पार्ट, क्या होता है, टू लर्न फर्स्ट कि क्या होता है, देन विल सी क्यों होता है. आप इसको गो थ्रू करें अपनी बुक से. एंड थ्रेशोल्ड एंड स्पीच डिस्क्रिमिनेशन एंड साइट ऑफ द लीजन वी हैव ऑलरेडी सीन. सो investigations, as you pass and go, you will be a certified medical practitioner and the onus comes on you that you should know what investigations are there to be done. If you don't know the investigations to be done, then it's a crime. आजकल हर कोई कमेंट कर देता है कि साहब डॉक्टर साहब जांचें बहुत लिख देते हैं, ये कर देते हैं, वो कर देते हैं. तो you should have a justification for whatever you are writing. Okay? So what investigation we have to do? History plus. We have taken the history, then what we will do? Physical examination. Because there are certain situations in which the body systems are involved and the ear is affected. Okay? सिस्टेमिक इन्वॉल्वमेंट की वजह से ईयर का इन्वॉल्वमेंट हो गया, तो द प्राइमरी डायग्नोसिस इज समथिंग डिफरेंट, नॉट द हियरिंग लॉस. यू हैव टू सी द बॉडी सिस्टम्स ऑल्सो. द बेस लाइन इन्वेस्टिगेशन इन एनी हियरिंग लॉस इज प्योर टोन ऑडियोमेट्री. प्योर टोन ऑडियोमेट्री से क्या पता चलता है? द टाइप, the severity and the grade. These 3 are the basic things which you should be aware while reading the pure tone audiometry. Impedance audiometry. Impedance test is basically done when your tympanic membrane is intact and you have to check the middle ear function. It has 2 components. One is known as tympanometry. The tympanic membrane, you cannot check the resistance, so you check the impedance. Okay? And the second part is stapedial reflex. Stapedial reflex is checked in cases where you want to know the level of the 8th nerve injury or 7th or 8th nerve injury both. Plus minus. Apart from these tests, we can also go for speech audiometry, evoke response audiometry, autoacoustic emission, and BERA, that is brainstem evoked response audiometry. These all might sound quite alien to you, क्या बोल रहा है ये? But don't worry, by the end of your year you will be well versed with it, don't worry. ये सब practical aspect है. What I am trying to teach you is to have a basic outline in your mind that whenever you are taking history of a patient of hearing loss, you have to mandatorily go through these points. Got my point? And then comes the laboratory test. It depends upon the suspected etiology, like CT or MRI of temporal bone. That is not done in every case. We can also go for X-ray. Complete blood count, blood sugar, serology, thyroid profile, and renal function test. So here are some common causes of conductive hearing loss and approximate hearing loss in decibels. If we say that the common causes, if we talk about common causes, it means anywhere starting from your pinna and going up to oval window, whatever mechanism is there, it is all concerned with conduction of sound wave. Okay, so whenever you are being asked कि conductive hearing loss के causes क्या क्या होते हैं, तो don't find yourself blank. यहाँ से शुरू करो कि भाई कंजेनाइटल एनोमली है, पिन्ना की एनोमली है, पिन्ना ही नहीं है उसके पास, एक्सटर्नल ऑटरी कैनाल नहीं है, मिडिल ईयर में ऑसिकल्स नहीं है. ठीक है. See, the occlusion of external auditory canal by anything, be it foreign body, be it wax, anything, be it a furuncle, it can cause a loss of around 30 to 40 decibels. Perforation of tympanic membrane depends on the size as well as site of the perforation, that you will read in chronic otitis media. It can range from 10 decibel to 40 decibel. Ossicular disorders, we have 3 ossicles, you are well aware, I think. Malleus, incus, stapes, पता होगा नहीं, इतना तो पता ही होगा यार, ऐसे क्या कर. चलो, they can be fixed, the joint can be fixed, or the joint discontinuity can be there, and it can be present with tympanic membrane perforation or without it. Okay, so they both are separate pathologies. The perforation of tympanic membrane does not warrant that ossicular disorders may be present, and otherwise also, if you have an intact tympanic membrane, you can also find ossicular discontinuity. Got it? So it can be up to 54 decibels. Ossicular disorders fix or discontinue with perforation, that is 38 decibels. So you might be thinking, when there is a ossicular disorder and without tympanic membrane perforation 54 decibel का लॉस है, अगर भाई फिर परफोरेशन हो गया तो उससे तो लॉस बढ़ना चाहिए. ऐसा नहीं होता. राउंड विंडो, देन राउंड विंडो एक्ट्स एज योर हियरिंग मेम्ब्रेन, सो द हियरिंग लॉस डिक्रीजेज. ठीक है ना. वहाँ राउंड विंडो पे एयर पहले साउंड एनर्जी पहले स्ट्राइक कर जाती है, तो आपको रिवर्स रिट्रोग्रेड सुनने लग जाता है. ठीक है. मैलियस फिक्सेशन 10 to 25 decibel and closure of oval window, as in case of otosclerosis, that is 60 decibel. So if you see in this range, the maximum level of hearing loss we see here is 60 decibels. Okay, so maximum hearing loss from conductive part can be 60 decibels. This is very important. Differential diagnosis. How will you differentiate that this is a case of conductive hearing loss and what type of conductive hearing loss, what is the reason behind it. So we will see the tympanic membrane first. If it is not visible, so abnormal external ear canal. By abnormality we mean it can be congenital, it can be acquired, it can be anything which is present in canal. There can be atresia, impacted wax, foreign bodies, otitis externa, that is inflammation of skin of the external auditory canal. There can be tumors of external auditory canal, fracture of the temporal bone, which might lead to maceration of external auditory canal as well as hematoma in the canal, and osteoma. If it is visible, if the tympanic membrane is visible, then the canal is normal. Then we have to see the tympanic membrane. If the tympanic membrane is normal, then what can be our differentials? Number one is ossicular disruption, might be due to temporal bone fracture or slight trauma, or we technically or clinically, if we say, we see cases. Recently we saw a case जिसमें one person was saying that I have been having bouts of sneezing since last 10 days and now I am not able to hear. ठीक है, उसको बहुत तेज़ी से छींकें आ रही थी, तो इतना ज़्यादा बैक प्रेशर जनरेट हुआ कि उसके ऑसिकुलर डिसकंटिन्यूटी हो गई. That we saw very recently. So other is congenital fixity of the ossicles, autosclerosis. There can be white mass in middle ear, which is congenital cholesteatoma, or the colored mass in middle ear, that is known as glomus tumor. Glomus pathology में पढ़ा होगा, है ना? नहीं यार, कोई बात नहीं. Abnormal tympanic membrane, if we are able to see, हाँ क्या? If we are able to see that tympanic membrane is not normal, it can be bulging. Bulging tympanic membrane we generally see in say toddlers or children around the age of 10-12 years, or it can also be seen in adults also, but generally seen in pediatric age group. This is considered as acute otitis media. It is a separate chapter altogether. Then we can see the perforation. It is known as otitis media, chronic otitis media. It can be suppurative or non-suppurative, and if there is perforation that is marginal, then it is considered to be a cholesteatoma, or if the perforation is in the center of the tympanic membrane, it is considered safe. Abnormal tympanic membrane with severe retraction. There is no mobility of tympanic membrane on Valsalva maneuver, that is adhesive otitis media. Tympanic membrane is adhered to the middle ear, medial wall of middle ear. It is quite painful condition. And if there is mild retraction, restricted mobility of tympanic membrane, it can be otitis media with effusion. You will definitely see some amount of clear fluid, water with air bubbles behind the intact tympanic membrane. Patient will give history of preceding event of upper respiratory tract infection. And the other one is barotitis media. It occurs after air journey. What is management? If there is removal, we have to see if there is impacted wax, foreign body, osteoma, exostosis. These all are fancy terms. फिर वही जैसे जैसे ENT का ज्ञान होगा आपको, आप आगे पढ़ोगे, you will be well versed with it. Tumors, stenosis. So the removal of external auditory canal obstruction by any mean, by any procedure in your outpatient department, or you have to do surgery for it. ठीक है? Acute otitis media, initially it is treated with medical therapy. If it is resistant to medical therapy, then laryngectomy. making an incision in the tympanic membrane is known as laryngotomy. Otitis media with effusion, if there is fluid behind the intact tympanic membrane, what you will do is you will make an incision, means you will do a laryngotomy and you put a tube, small tube, that is known as grome. So laryngotomy plus grome. If there is otosclerosis, that is fixation of stapes, foot plate, you will do stapedectomy, stapedotomy. If there is tympanic membrane perforation and ossicular discontinuity, we will do tympanoplasty. And when surgery is not possible or refused or failed, then hearing aids. And if we talk about differential diagnosis of SN loss, so the most important thing is onset. Whenever you ask a patient that since when he or she is not able to hear, they give a very vague reply. जब मेरा पोता पैदा हुआ था, या या उसकी शादी हुई थी. अब आपको क्या पता कब हुई थी, वो भी उनको आइडिया नहीं रहता. Then you make a inference, yes, he is having a hearing loss, you do tuning fork test. And if they are saying it is gradual, then we have to determine whether this is asymmetrical or symmetrical. By symmetrical, you mean that it is equal on both sides after documenting it. Documenting it with what? Pure tone audiogram, and if in any case, if required, tympanometry. ठीक है? So it can be, if it is gradual and symmetrical, they can be ototoxic medication which had been given previously. Noise exposure, noise induced, you will see a notch at 4 kilohertz in pure tone audiogram. Pure tone audiogram is a separate chapter. And age related, most common what we see. And if you being asked कि भाई सबसे common cause क्या है SN loss का, then it is aging, presbycusis. And if the gradual onset and asymmetrical hearing loss, we'll go for imaging. Asymmetrical means एक कान में hearing loss है और दूसरे में SN loss नहीं है. Then we have to find out what is the cause which is there. If in imaging something abnormal is found, generally what we get is either it is a glomus tumor, glomus tympanicum, glomus jugulare, you will read, or a CP angle tumor, cerebellopontine angle, जहाँ से 8th nerve निकलती है ना, cerebellopontine angle, वहाँ पे बहुत सारी स्ट्रक्चर्स होती हैं आसपास में, नर्व्स होती हैं, उनका किसी का भी ट्यूमर हो सकता है, हेमेंजियोमेटस हो सकता है. ठीक है. And if we see the onset is acute for a sensory neural hearing loss, we will first ask the patient about any history of trauma. Okay. It can be barotrauma, it can be iatrogenic trauma, that is surgery induced trauma, it can be blunt or penetrating trauma, or it can be acute noise trauma. ठीक है. आप ये देख रहे होंगे नॉइज एक्सपोजर सिमेट्रिकल, ग्रेजुअल सिमेट्रिकल में देखिए नॉच एट 4 किलोहर्ट्ज, और एक्यूट ट्रॉमा में भी टिनाइटस एंड नॉच एट 4 किलोहर्ट्ज. सो इट इज द नॉइज ट्रॉमा. इन नॉइज ट्रॉमा on audiogram you will find a notch at 4 kilohertz. ठीक है. It is almost always diagnostic for it. And if we see acute onset with no history of trauma, then we have to rule out whether this hearing loss is fluctuating or not, stable है. ठीक है. Onset, acute onset with no history of trauma and stable hearing loss, it is considered as sudden sensory neural hearing loss. Okay. Sudden means मतलब फिर वही definition की बात आ जाती है. On 3 consecutive audiograms at 3 consecutive speech frequencies, that is 0.5, 1 and 2 kilohertz, you will get a airborne gap of more than 30 decibels is considered as sudden sensory neural hearing loss. Sudden why? Because the duration is very less. It is less than 72 hours. ठीक है. SN loss तो आपको पता ही है, उसमें कंपोनेंट आ ही रहा होगा जब आप ऑडियोग्राम कराओगे. Other one is fluctuating hearing loss with no history of trauma and acute onset. It is seen in Meniere's disease. It is a inner ear disease. It is also known as inner ear hydrops. जो इनर ईयर का फ्लूइड जो होता है ना, एंडोलिम्फ, वो उसकी क्वांटिटी बढ़ जाती है, whether due to decreased absorption or increased production. So the organ of corti gets distended. ठीक है. तो जो टेक्टोरियल मेम्ब्रेन होती है, जो हियरिंग के लिए बेसिकली रिस्पॉन्सिबल होती है, इट गेट्स डिस्टेंडेड इनटू द पेरीलिम्फ, तो टुवर्ड्स पेरीलिम्फ. तो उस पर प्रेशर आ जाता है. एक लिमिट तक ही प्रेशर वो झेल सकते हैं, फिर वो बर्स्ट हो जाता है. तो पेशेंट को उस टाइम पे पहले हियरिंग लॉस होता है, फिर वर्टाइगो और टेनाइटस होता है. जैसे ही वो बर्स्ट होता है तो उसके सारे सिम्टम्स रिलीव हो जाते हैं, फिर वही साइकिल चलता रहता है. तो दैट्स वाई फ्लक्चुएटिंग हियरिंग लॉस इज देयर. द अदर वन इज high frequency SNHL. This is seen in immune complex mediated SNHL, and it is very hard to diagnose. So what about the management of SN loss? These are two prime things which you should always consider whenever you get a patient of SN loss. The early detection and immediate attention. Early detection is in your, say now, अगर पेशेंट ही लेट आ रहा है तो अलग बात है. अगर आता है, सपोज सडन सेंसरी न्यूरल हियरिंग लॉस का पेशेंट आता है, एंड इफ यू आर नॉट एबल टू डायग्नोस, देन आई थिंक इट्स अ क्राइम. आप उस पेशेंट को जिसकी हियरिंग प्रिजर्व कर सकते थे, आप उसकी हियरिंग प्रिजर्व नहीं कर पाओगे, और दे माइट एंड अप बीइंग डेफ. एंड इमीडिएट अटेंशन शुड बी गिवन टू दिस काइंड ऑफ पेशेंट, and early measures to stop and reverse the progress and rehabilitation program. What are the treatment options for different causes? Syphilis is one of the cause of SN loss. We can give, you all know, penicillin. Okay. Hypothyroidism, thyroxine replacement therapy. Labyrinthitis, that is inflammation of membranous labyrinth. Treat the active middle ear infection. The fistula of the perilymph, surgical correction, ototoxic drugs, immediate discontinuation. Acoustic neuroma, that is a cerebellopontine angle tumor. It requires surgery or stereotactic radiotherapy. Sudden SNHL requires steroid or antiretroviral therapy. Rehabilitation with hearing aids and cochlear implant is also there. If the patient is having mild to severe bilateral SN loss, hearing aid is prescribed, and if he is having bilateral profound SNHL, then we will do cochlear implant. So it's a case for all of you. Please go through it. Please go through it. Read it. Whatever inferences you can make out of it, and from, I think, each side कोई एक इंटेलिजेंट आत्मा खड़ी हो और बताए. दिख रहा है? See, from this time onwards we will be introducing OSCEs. होते हैं आपके? OSCE हुए थे क्या अभी तक? OSCE, OSPE एग्जाम के पार्ट होते हैं, हुए थे क्या? चलो इस साल से होंगे. तो यू माइट बी गेटिंग दीज काइंड ऑफ केसेस वेर यू हैव टू राइट all the answers correctly in order to get a number. Suppose this question is of 4 marks, है ना? We are having 4 questions in it and it's of 4 marks. हर क्वेश्चन का एक नंबर है मान लो. अगर एक आंसर दिया इसमें से सही तो 1 नंबर और 4 दिए तो 4. ठीक है, ये एग्जाम का पैटर्न होएगा आपका प्रैक्टिकल का. व्हाट कैन वी मेक आउट ऑफ इट? नंबर 1 इज एज. A 40-year-old male. Hearing in both ears, bilateral, for 5 years, gradual. Onset was gradual, that he does not remember how and when it started. He has gradually progressive painless hearing loss in both the ears. एक लाइन में सम अप कर दिया. ग्रेजुअली प्रोग्रेसिव, पेनलेस, एक्यूट नहीं होगा, हियरिंग लॉस इन बोथ ईयर्स, बाइलेटरल हो गया. तो बाइलेटरल, ग्रेजुअली प्रोग्रेसिव, पेनलेस हियरिंग लॉस. ड्यूरिंग वर्किंग आवर्स while talking with colleagues they had to shout as the hearing loss get worsened in the presence of noisy background. ठीक है, तो कॉक्लियर पैथोलॉजी डिफाइन हो गई. He has been observing that loud sounds make him irritate. This is known as recruitment phenomena. Now he finds difficulty in hearing during the normal conversation. He says, I can hear but cannot understand what the person is saying. Okay, so it is also a defining thing for a cochlear pathology. Sometimes he has sensation of oral fullness, oral means ear, and tinnitus, and muffled hearing after the work. He does not give any history of dizziness, ear discharge, ear pain, headache. Ear discharge नहीं है तो middle ear and outer ear pathology वैसे ही rule out हो गई आपकी. Dizziness नहीं है तो inner ear की और कोई हाई प्रेशर पैथोलॉजीज होती हैं वो सारी आपकी वेस्टिबुलर पैथोलॉजीज होती हैं वो चली गई. एंड हेडेक भी नहीं है तो रेज्ड इंट्राक्रैनियल टेंशन भी चला गया. एंड अदर कॉजेज ऑफ हेडेक. ही एडमिटेड दैट ही हैड बीन स्मोकिंग सिगरेट्स फॉर 20 years एंड डिड नॉट गेट टाइम फॉर एक्सरसाइज. His diabetes and elevated blood pressure were diagnosed 2 years ago. So these are all add-on factors to the complaint he is having. Uncontrolled diabetes and uncontrolled blood sugar, blood pressure, along with the smoking part. He works in an industry where he is exposed to lot of noises from the machines. ठीक है, वर्क हिस्ट्री उसकी ये बताती है कि वो जहाँ काम करता है वो एक फैक्ट्री सेटअप है, इंडस्ट्रियल सेटअप है, जहाँ पे वो कॉन्स्टेंटली लाउड नॉइज से उसका एक्सपोजर है. He could not explain the frequency and intensity of noise emitting from the machine. He works for 8 hours a day and 6 days in a week. ठीक है, because there are certain guidelines which are prescribed by Ministry of Labor. वो ये कहते हैं कि भैया लाउड नॉइज इतनी डेसिबल तक परमिटेड है और इतने आवर्स डेली से ज़्यादा. अगर सपोज करो किसी इंडस्ट्री में 100 डेसिबल की नॉइज जनरेट हो रही है तो वहाँ कोई भी व्यक्ति 9 घंटे काम नहीं कर सकता. दे हैव टू वर्क लेस देन 6 hours और 8 hours. ठीक है. जनरल सर्वे एंड एग्जामिनेशन डज नॉट रिवील एनी फाइंडिंग. Rennie was positive. So Rennie positive we can get in 2 situations: normal hearing or SN loss. Weber did not lateralize to any side because we already read that it is equal. Bilateral था ना और equal था. ABC was found reduced. Absolute bone conduction test is being performed when we consider that the examiner हैज़ नॉर्मल हियरिंग, अगर मुझे करना है और आपका करना है तो इट इज़ कंसीडर्ड दैट आई हैव नॉर्मल हियरिंग। अगर मेरी हियरिंग नॉर्मल नहीं है तो आई एम नॉट फिट टू डू दैट। ठीक है, तो उसके दो इन्फ्रेंसेज होते हैं, इट इज़ इक्वल टू एग्जामिनर ऑन राइट ईयर और इक्वल टू एग्जामिनर इन लेफ्ट ईयर, और इट इज़ रिड्यूस्ड। ठीक है, ABC was found reduced showing SN loss. So the questions here are, what could be the cause of hearing loss? Cause क्या हो सकता है इतनी बड़ी हिस्ट्री में, क्या कॉज लग रहा है? Loud noises, very nice. So it is a case of noise induced hearing loss. ठीक है, ठीक है, एक्यूट नहीं, क्रॉनिक है, लाउड नॉइज से क्रॉनिक एक्सपोजर की हिस्ट्री। What further investigation you will advise to this patient? पहली बार आया ना आपके पास, तो कुछ एक आध के नाम बताओ। प्योर टोन ऑडियोग्राम, टिम्पैनिक मेम्ब्रेन नॉर्मल है, तो और क्या कर सकते हो? इम्पीडेंस ऑडियोग्राम। ठीक है, उसके अलावा और क्या करवा सकते हो? हाँ, ऑटोकोस्टिक emission has no value per se in this case, but you can go for BERA, brainstem evoked response audiometry. BERA is a very very clear test, जिसमें आपको ये पता चल जाता है कि पेशेंट के कहाँ पे पैथोलॉजी है इस पूरे सिस्टम में, जहाँ से साउंड वेव होके और सेंट्रल सिस्टम्स तक जाती है। तो यू विल कंफर्म योर ऑडियोग्राम्स रिजल्ट विद BERA। ठीक है, द अदर थिंग इज, वो फिर आप आगे पढ़ेंगे कि ऑडियोग्राम को पेशेंट, इट इज़ अ सब्जेक्टिव टेस्ट, सो इट इज़ अ वेरिएशन, सब्जेक्टिव वेरिएशन। एक पर्सन टू पर्सन वेरिएशन भी आ सकता है और पेशेंट टू पेशेंट वेरिएशन भी आ सकता है, तो पेशेंट उसको गलत भी बता सकता है। तो देर आर हाई चांसेस ऑफ मेलिंगरिंग इन दीज केसेस, सो यू रूल इट आउट विद BERA। हाउ विल यू मैनेज दिस पेशेंट? अभी अपन ने एक फ्लो चार्ट पढ़ा था, क्या कर सकते हैं? कुछ कर सकते हैं? ऑलवेज आंसर लाइक दैट इफ वी गेट a patient, if we get that result out through PTA, that patient is having bilateral moderately severe, mild to moderate hearing loss पढ़ा था ना, hearing aid, so we will give a hearing aid trial to the patient, number 1. Number 2, if he is working in a factory surrounding, we'll make sure that he'll get his hearing checked periodically. Number 3, what we can do is we can give him प्रोटेक्टर्स ऑफ हियरिंग, ईयर मफ्स, ईयर कफ्स आते हैं ना, जो आप स्विमिंग के टाइम में लगा के स्विमिंग करते हैं, वैसे टाइप के आते हैं। कुड हिज डिजीज बी प्रिवेंटेड? इफ यस, मेंशन द प्रोफाइलेक्टिक मेजर्स। तो वो जो अभी मैंने बताया, दीज आर ऑल्सो दी प्रोफाइलेक्टिक मेजर्स फॉर इट। सो मैंने जितना पढ़ाया, अगर आपको उसमें से 25% भी आज समझ आ गया, तो इस तरीके के जो आपसे केस सिनेरियोस प्रेजेंट होंगे, जो आपके थ्योरी एग्जाम में भी आएंगे और आपके प्रैक्टिकल में भी आएंगे, तो आपको जो आउटलाइन है उसको पढ़ के जाना है। ठीक है, ठीक है, हो गया, ये कह रहा जाओ। चलिए, थैंक यू। अच्छा भैया, अटेंडेंस कैसे देनी है? आप यहाँ